All right. Good afternoon, everybody. Thank you for coming. Appreciate you being here at the Oklahoma Healthcare Authority. My name is Nico Gomez. I'm CEO of the Oklahoma Healthcare Authority, and we're gonna. Should we have more feedback? All these technical advances. We're actually online, so the microphones that are above your head will pick up conversations that you have. So if you have sidebar conversations, they may get picked up online. We'll have Uh, we have had a number sign up, so we know there's quite a few folks online, and there'll probably be some more folks coming in. I want to be respectful of your time. Uh, Thanks for coming. It really does. We didn't know if we're going to have an empty room or wall to wall. We know we had a lot of folks online, so I'm glad you're here. This is an important time in our state and an important opportunity that I want to visit with you about, and very just about uh, excited about opportunities, frankly. Want to get started just to say this is a joint venture. This is while I'm up here with the Oklahoma Healthcare Authority giving you what I'm calling the Medicaid Rebalancing Act or Plan of 2020. This is a joint venture between the Health and Human Service cabinet agencies under Governor Fallon. Great partnership with the Department of Mental Health and Substance Abuse Services. Great partnership with the Health Department. They both have folks here in the Cabinet Secretary's office. We're in this together. And we're in this together not only from the agencies, we're in this together as communities and as Oklahomans. And so I'm going to spend about 20, 30 minutes to walk through what is the Medicaid Rebalancing Act or plan, and why are we here? What's some of those conversations that we're having? This is one of several public forums that we'll be having. Tomorrow we'll be in Lawton. This is the only one that we're going to be streaming online, but we'll be in Lawton tomorrow. Next week, I believe we're going to Muskogee and Tulsa. Those are actually on our website. Those of you online should be able to, I believe, download the handout. Is that true? Okay, so I'll make sure I'm seeing. Yes, okay. So online, you can kind of see the handout. You can download that. If you're here in person, obviously you can pick that up when you signed in. And then after I kind of go through the handout, uh, we're actually going to field some questions and comments. We've got some scribes here because the beauty about is this plan is under construction. There's opportunities for us to make it better, more responsive to your feedback, to your ideas, and to make sure that we are serving Oklahomans the best way we can. All right, we good? All right. So I'm going to start. And I'm actually going to start with the budget scenario, so you can kind of frame up kind of part of the conversation of why we're here. And so if you look on your piece of paper, because one of the things that I kept hearing recently, because last Tuesday, we had to start our public notification process to deal with the provider rate cut. Absolutely nothing we wanted to do. Last thing we want to do, our board has always held a very long tradition of maintaining our provider rates at the highest rate possible. Well, since 2010, we've cut, uh, when that revenue failure occurred, 2009, 2010, there's been a lot of cuts in the budget. And really, in the last 2 years, we've cut nearly $500 million out of the budget. And those impacted a lot of providers and some of our members because there are some benefits that we don't want to recover. As each cut gets deeper and deeper, uh, it gets more difficult, it gets more painful. And really, we're to the point where most of you who are familiar with Medicaid program, when you're adjusting the budget either up or down, it's about who qualifies for the program, impacts your budget, and what kind of benefits you're providing impacts your budget, and how much you pay your providers impacts your budget. Well, we're pretty much limited right now on who qualifies for the program. We are under what we call the federal maintenance of effort until October 1 of 2019. That actually plays into our plan a little bit. So we're pretty much limited, and we can't reduce who qualifies for the program. We have some optional benefits that are still optional benefits. These are uh, benefits that the federal government says you don't have to provide as a state and not lose all your federal funding. But there really is nothing there in the optional benefits that save you money. Pharmacy program, for example, is an optional benefit. But if we terminated the pharmacy program, it doesn't save any money. It actually pushes cost into our inpatient side of the ledger. So that kind of leaves us with provider rates. And so unfortunately, as we continue to look at what's going on with our budget, each cut we're dealing with is going to be focused on provider rates. So that's why I want to start with this chart. Because when I said we may have a 25% provider rate cut. The feedback that I was getting, and I won't be specific with who, because it doesn't really matter. The feedback I was getting is that it was just a smokescreen, not real. So let me be able to defend and explain why we put forth a 25%. Just started the public notification process. I hope at the end of the day that's not the case. But a lot of things we have to deal with as a state in order to avoid that. So when the governor put out her state of the state and she put out her budget first day of session, she gave different scenarios. And one of those scenarios is if we didn't get and deal with some of the structure of the budget, agencies could be cut 13.5% in their appropriation. Well, that was before the second revenue failure, and that was before the Board of Equalization met and certified that they're going to have $1.3 billion less to spend this year. So, somewhat of an estimate, we said, okay, 15% cut to our appropriation is not unrealistic. I absolutely hope it doesn't happen, but it's not unrealistic in our current financial situation. So if we had to do that, what does that result in terms of provider rate cut? Well, so we went to this chart, and and actually this was kind of a doodle on my kitchen table last night, but it made sense to me. So right now, because FMAP, what is FMAP? That's our federal medical assistance percentage. That's the formula that says how much federal funds each state's going to get based on a 3-year rolling average of the state's per capita income. We have seen a decline in our federal dollars consistently over the last few years, partly because Oklahoma has had a very strong economy when you compare it to the rest of the country. It really has been strong because of the oil and gas industry. And so it results in that 3-year rolling average that we're still dealing with less federal dollars. So we have to replace the federal dollar. We also have Medicare A and B requirements. So there's some cost shift on the Medicare side to the Medicaid program. And so those are the Medicare requirements. Then there's the revenue failure, the 3% and the 4%. There may be another revenue failure after that. We don't know. The Treasury's office came out yesterday. We are still well below what we were in our projection. So, and then you got inflation. We actually put medical inflation at about 1% in terms of how much growth and utilization we project to have in the program next year. So what that means is for us to have an 86.5% provider rate, which is what our rate is today, the hole we have to fill is $100 million. And that takes care of everything I just went through: the loss in federal funds, the 7% provider, or the 7% revenue failure, basically annualizing that next year. That's where that $100 million. So before we even start with before the legislature, because we're not in it, with the legislature and governor, before they even start budget negotiations, we're already dealing with $100 million shortfall because of that. So in order for us to maintain 86.5%, we've got to come up with $100 million more, and that's a very difficult situation to be in when you have a $1.3 billion deficit. So we're dealing with the reality. We will deal with some cuts. We just don't know how deep. So as we went back to the governor's budget and looked and said 15% deep, a cut to our appropriation is deep. What does it result in? Well, it increases that hole to $235 million within our $5 billion program. These are state dollars, and we get matching federal dollars. And so that results in a provider rate, effective provider rate of 64.9% when we compare it to Medicare. That's kind of our measuring stick that a lot of states use to kind of see where you are in rate. I believe 75.7% is if we were a flat budget, held harmless. Or actually, yeah, in other words, we didn't have another cut. We still had to deal with our deficit. It puts us at 75, nearly 75.5. That puts us roughly in the regional average of all the states next to us. But that doesn't necessarily mean that we can survive that deep a cut that quickly. So there's a lot of factors that we're having to deal with. We kind of saw this train coming. So we actually have been working with the Healthcare Authority and other agencies to go. We can't continue. We can't, on top of the $500 million, on top of what the potential cut's going to be, And most people will tell you to expect more cuts next year in 18. Of course, a lot of that depends on what happens to oil gas and some other things that are happening around the world, how that impacts them. We decided we can no longer just continue down the road until we get to the point that the whole system just breaks. We have to provide an option, not to preserve the healthcare authority, not to preserve hospitals or nursing homes or other providers, to preserve the healthcare system for everybody in the state of Oklahoma who needs healthcare. That's how serious it was to us. And that's how important it is for us to have the conversation, because at the end of the day, it really isn't about me or the agency or the program. It's how are we going to be able to deliver care to our citizens who need help? Because we cover more lives than anybody else in the state. We underpin, right or wrong, positive or negative, we underpin the entire system. So this, and if you're rural Oklahoma, you're probably a little bit more sensitive to our rates than you are in urban Oklahoma. But the fact is, if urban Oklahoma starts to falter, everybody's coming to urban Oklahoma. It doesn't, you can't, we don't live in these silos. We are impacted by what happens in our communities. So we said, we cannot continue to go this way. So I've been having conversations with my board and going, I want to offer something different. We've been challenged by the governor and the speaker and the president pro tem, say, bring us ideas, bring us something innovative. Don't bring us just your handout saying, this is what my problem is, bring us a solution. So we did it. And is it the best plan? No, probably not. It's not perfect. But it's the only plan right now that's on the table. And if somebody has a better one, please bring it forward. We would love to see a better plan. I will go through the parts of the plan, and then I'll tell you what some thoughts are on funding it. Because anytime you have a plan, you're going to have to deal with funding at some level. So, frankly, if we weren't dealing with the provider rates and we weren't dealing with the budget deficit, the plan is fairly budget neutral. But we are. But that's our reality, is we're dealing with the budget. So we got to deal with it in that context. So if you go back to that top, I'm going to go back to that little balance up here. We talked about what the Rebalancing Act is and isn't. When we were challenged to come up with something innovative, they said, you cannot bring us Medicaid expansion. Great, we won't do it. If we're not even going to be able to have the conversation, then we will not bring you Medicaid expansion. This is not Medicaid expansion. I know there will be critics that argue that it is. I will argue that it's not. For a number of reasons. There are some very difficult decisions. It's a 4-year plan. So it's not all going to happen in year one. But over the 4 years, what I believe we'll accomplish, should we be successful, is actually reducing the size of the Center Care program, reducing the size of the entitlement. That's scary for a lot of people. And I'll explain why. When we say that, it doesn't mean we're just pushing people into the abyss or pushing people into some uninsured status. That's not the case at all. We also are going to be able to provide a new Insured Oklahoma option for individuals. And we'll talk a little bit more about that more specifically. Be able to reduce the number of uninsured through that new Insured Oklahoma option. And we actually believe we'll be able to get better health outcomes long term if we set it up right. So as we kind of go forward, the reason why it's not Medicaid expansion is because my Center Care number is actually going to go down over 4 years. By our projection, 22%. And there's a lot of confusion because there's 275,000 estimates of people in this plan. They offset each other. And I'll explain why. Because when we talk about moving folks from Center Care into the commercial or private market, we're actually taking them off our financial responsibility. Now, that doesn't mean we're just going to put them again out on an island. We want to use the advanced premium tax credits they have today available to them, that they'll have available to them on October 1 of 2019. Take those tax credits they have today and help them purchase insurance. We want to make sure it's affordable. We want to make sure it's accessible. Because I want to suggest if it's not, then we don't do it. But I think that has to be part of the plan. The plan has to be, we have to reduce the size of the entitlement to make this work. And so, but making sure that at the end of the day, that everything that we do centers around the prosperity of the people we're trying to serve. upholding that principle of human dignity. And so that's critical in everything that we do. That's the forefront of our mindset. So as we go forward, I want to tell you a little bit about how rebalancing works for that bottom piece. A new Insured Oklahoma plan. We're going to reduce the number of uninsured by 175,000. Those people who are uninsured today, put them in a new Insured Oklahoma model. Now, these are adults between the age of 19 and 64 that are below 133% of the federal poverty level. These are people who don't qualify for any subsidy, but for the most part are out there working uninsured, working without a safety net. And this is an opportunity to provide quality, credible coverage to them in a way that's responsible, in a way that is effective. So the idea here is this, and when I say it's an idea, there's a lot of detail that we have to work through. So as we go through it, and you have thoughts and feedback, whether you're online or in person, if you're online, there's a place that you can leave comments and questions. We'll get back to you. We'll respond. Because as we go through this, there's opportunities to make this better. But here's the vision right now as we kind of talk about the Medicaid Rebalancing Act. So you have the Insured Oklahoma program, a new Insured Oklahoma program available for individual adults. Again, 19 to 64, below 133% of the federal poverty level. And so it's going to look, for me, it's the state employee. That's kind of how I visualize, probably how it kind of influenced that way. It's a flexible spending account. Some of you have those in your own business. So a person's going to come in, they're going to qualify. We're going to be able to, we use technology. So if somebody's going to be able to come in online, we're going to be able to qualify them. And they're going to be able to choose from different plans. They're going to have a minimum benefit, because that just makes sense. There needs to be a minimum benefit standard. Beyond that, we've been working with Department of Mental Health and Substance Abuse Services because we want a robust behavioral health and substance abuse benefit with it. And we want zero or low deductible plans. So we'll have to work with the carriers to make that happen. I believe the market's there because we're talking about putting 175,000 people into that market, and I believe we can get there and make it affordable for the state, for the individual. So how that works is, so somebody comes in, computer, they're walking in, and we're going to go to the carrier and say, hey, we got 175,000 folks ready to buy insurance. Come to the market. Come to your market. Bring it to Insured Oklahoma, a lot like we do with the employer-sponsored plans in Insured Oklahoma today. And so they'll make that selection, and there may be opportunities for them to buy a vision rider or a dental rider. We're talking comprehensive health care to make sure that we have a productive workforce. Again, focused on the individual and their success. So as we go through that, now we'll get to how it's funded and all that stuff. We'll spend a little time on that. So in addition to that, I want to create it's a savings account. It's really a health savings account. Now, it's not the IRS health savings account. Some states have looked at it a little differently, but this is an idea where we can create an account that comes alongside the individual. And this is where where the magic could happen. This is where you can make investments as an individual and save money towards future premiums or future co-pays, or if there's a deductible, future deductible. Wouldn't it be great if we had a way to match money that people were saving towards their health care? Wouldn't it be great if we had a way to incentivize their savings towards future healthcare expenses, and that we could reward them for, if they were diabetic, that they were keeping their diabetes under control, if we could reward them for getting preventive screening? I think that's real. I think that's an opportunity, again, to invest in the individual. And so maybe it's outside the house of medicine. We know there's an opportunity cost to go back to school. So maybe somebody's going back to school to upskill, to improve their income mobility. And so they go back to school, and while they're going back to school, we actually make sure that they have enough money in their account. So if they get sick, that they're able to take care of their health care. Tremendous opportunities there. And this kind of a health savings account that kind of comes along the individual. And I think that actually, because people say, well, what about, can you mandate people participate? No, we can't mandate people participate. That's not Oklahoma. It's not our standard. But can we incentivize folks to take charge of their own health care? I think we can. And I think we can go through and collaboratively work on it. What I love about having everybody in this room and everybody online is that this reality, wherever you are in support or against or neutral on this, that we do care about our neighbor in the state of Oklahoma, and we actually have an opportunity to do it right. But we have to get out of the survival mode that we've been in and get into creative mode. And I think we can get there. And I hope you'll join.
So there's kind of the Insured Oklahoma look, and we can answer some more questions as we go forward on that.
The Sooner Care transition, 175,000, these are 175,000 Oklahomans who are in the program today, that on October 1 of 2019,
A little over 3 years from now,
we can transition into a different product using their
advanced premium tax credits. It takes them off the Sooner Care Healthcare Authority
ledger in terms of funding, using their funding and helping them purchase insurance in the commercial market. There's a couple ways we can do that, but what I love about that,
given the opportunity, I think we can do that right.
and I think we can do it well,
And I think the individual would be better served. Does that mean they may have more out-of-pocket costs than they do today? Possibly. So who are we talking about? We're talking about
a population in the program today. We cover kids and pregnant moms up to 185% of the federal poverty level today. On October 1 of 2019, we can actually reduce that to 133%.
So we're talking about those moms
And kids above 133%
who are in Sooner Care today. That's why it's not Medicaid expansion. Because over the 4-year period, we'll be able to move them off our financial responsibility, help them get insurance
into a commercial market. Now, there's a couple ways we can do that. I mean, there's a new 1332 waiver, which is basically technical saying is there's new opportunities to do that with our federal partner, but we don't have to do it with our federal partner. There may be an opportunity for us to do it as a state without involving the federal government in that piece. But I want the opportunity to work on it with you together to make sure we do it right. Key piece to all this, and frankly, if that one piece doesn't get done,
this may be all for naught. If we're not able to prevent and restore Medicaid provider rates as soon as possible, it will destabilize the healthcare system. I've heard from you. I've heard from providers who said, if the rates go into effect, we will terminate our contract with healthcare authorities. I've got letters. I've heard from you. I've got email. I've seen the news stories. I know that our nursing homes are hurting. By the current rate we're paying, I know our hospitals are hurting, and that service lines may be discontinued. My board chairman, who happens to be in the back room, Ed McFall, last Thursday, he was actually going to be at the meeting with us at the Capitol. He couldn't go because he was inventorying the hospital in Tillman County because they're changing their line of business to outpatient only. The system's changing. Our responsibility is to make sure we provide access to Sooner Care members, regardless of their ability to pay. We will do that. The system is hurting. People are hurting. Families are hurting. We're not going to solve all this with this. But we can prevent a lot of future pain if we do it right. Provider rates is critical. If we are forced to cut rates, I'm not going to go back, but if you look on that page, and if you go back and we have to cut rates even 10 points, that I've heard from some of you said even a 10-point cut will force us to either stop seeing your patients or force us to move locations or force us to close altogether. Somebody told me the other day that the average age of the physician in rural Oklahoma is 61. We've heard from some of those who said, I'm too close to retirement. That's too much stress. They love their patients. They will take care of them, frankly, and we may never know it. But they're not going to deal with a rate that doesn't even pay them to keep their lights on. Very serious situation. Something that keeps me up at night. So as we go forward, you go, well, how do you pay for this? Number one, if we don't somehow secure and stabilize the Medicaid rates, none of this other stuff happens because it won't matter. You won't have a system. You won't have a system that's responsive to the needs of the state, the people in the state of Oklahoma. So what is the cost of the new Insured Oklahoma plan? Well, the good thing there is we can actually look at everybody in the room. I'm assuming you pay federal tax dollars. We can get some of your federal tax dollars back to pay for this program. We have your state tax dollars. We can use that to pay for this program. So the cost of the new Insured Oklahoma program, if we were to start January 1, and that's really aggressive, that scares my staff to death. But if we could start January 1, what does that look like? Well, from a standpoint, now we're using 176,000 people. Now, what that number is the number of people who we believe would participate. Now, does that mean that all 175,000 are going to come to the door day one? No, it doesn't. But I don't want to get accused of trying to undervalue the cost of it, and then all of a sudden spring up. So you've heard me say $100 million cost, and I'll explain how I got there. So if we were starting January 1, 6 months of the fiscal year, and they had 176,000 people who may come in, and that's 75% participation of who we know are uninsured in the state of Oklahoma. We know there's about 600,000 uninsured Oklahomans, and there's probably about 250 some odd thousand that are below 150%. So we just started kind of doing math, and we said if 75% participation rate comes in, we believe that's 175,000 Oklahomans. You'll see other states missed it low, so we said we'll miss it high because we didn't want to get accused of trying to undersell or undervalue the proposition. So you have 176,000 folks coming in. The state share cost of that for that 6-month period is about $26 million. So whatever a hole is plus $26 million gets us started. That may be a conversation we want to have with the hospital or the carriers or somewhere else about how do we get that started and funded. SFY 18, same number of people, so we know that'll ramp up. But worst case scenario, how much money do you have to have? Well, we have to have $63 million. And we're going to be able to bring in $993 million federal dollars back to the state. Not a bad proposition. SFY 19, the same, $74 million state. If you see here, what's happening is the match rates change. The match rate changes to 90-10 in the year 2020, and it stays 90-10 and 20 from there until they change the federal law. And so people say, well, what happens if they change the federal law? We can put a trigger in. It says if the feds change their matching rate for that particular, what is an optional program, not a mandatory program, but if they change the rules of the game, we as the state of Oklahoma can say we are no longer in business. We no longer want to provide that. Hard decision to make, but at least we can go and deal with that up front. So that's 90-10 and 90-10 from 21, 22 on out. So the benefits of all that is you're able to reduce the number of uninsured by 30%. You're able to reduce your sooner care enrollment on a monthly basis by more than 20%. You're able to save $55 million in state spending because you're being able to move folks from the traditional entitlement into commercial insurance using the advanced premium tax credits. I guess I should have said those folks above 133% in 2019-2020 will have access to the premium tax credit if they don't have Medicaid available to them. That's why it's not Medicaid expansion. Over 350,000 new people in the commercial market. I think that would help stabilize a lot of this issue that we're having in the commercial individual market. You know, premiums going up, things that we actually start to, hopefully, in theory, start to see that level out and maybe even come back to the benefit of the policyholder. $3 billion in economic activity, that's direct economic activity. But this, as I mentioned earlier, this impacts not only the Healthcare Authority Medicaid program, it impacts public health, it also impacts our behavioral health, mental health, and substance abuse systems. We would be able to either through the benefit, through Insured Oklahoma, through the benefit structure, or through the rate structure of maintaining the Medicaid rates, be able to start strengthening that system, improve, and maybe even expand mental health courts and drug courts. But for sure, keep crisis centers open. That's the thing that's real. We're so close to the edge of that cliff, crisis centers are actually in jeopardy. This program actually may help us stabilize. Not only stabilize that, actually start stabilizing the healthcare system. So that's kind of the tenets of the plan. I know you may have questions, you may have comments, and I would ask that you come to the podium, identify yourself, ask your question or comment. We'll put it down on the board and go from there. But I want to say a couple things. Thank you for coming. If you need to leave, I certainly understand it. Again, remember we're online, so anything you might say in the audience will probably get picked up. So make sure you come to the podium. We have a wonderful opportunity here to do some really good things for the state of Oklahoma. Again, if somebody has a better plan, I would hope they bring it forward. Time is running short. We're having to deal with this. One thing I forgot, I didn't mean to, is to go, well, how are you going to fund this? Well, we typically just leave that up to the legislature and the governor. But I will tell you from a public health standpoint, from from a reality standpoint, we believe that a $1.50 increase in the cigarette tax is the way to fund this for a couple reasons. Not because I want to go pick on smokers. That's not it at all. But a couple things. I have people come to me all the time. They said, "Why can't you charge your senior care folks more out of pocket?" Well, I can't. There's federal limitations on it. But I tell you what, we have a high percentage of folks on senior care and senior care parents who smoke. So if we're and then beyond that, so there's kind of a user fee, if you will. But beyond that, we know for a fact that taking care of people who smoke costs us 3.5 more times than people who don't smoke. So we're going to be paying for them one way or the other. My suggestion is let us use the revenue that tobacco companies make from selling a legal product to help offset the cost of the care that's going to be required to take care of them long term and make sure we have a system that will be there when they need it. So I think $1.50 cigarette tax is not unreasonable in this situation for this circumstance. So we're going to work with our colleagues in the health cabinet to make that argument. We usually, like I said, don't get involved until the legislature and governor how to fund it. But we believe this is a reasonable alternative to this situation. So with that, I'm going to grab a drink of water, come up to the podium if you have a question or comment. I'd love to hear it. And if you would, just tell us your name, please.
Way beyond me in accounting, and so I'm going to kind of state that right up front. But as a psychologist, I'm familiar with the Alameda zip code study. I don't know if you're familiar with that. But what the study showed in California, Alameda, California, is that you can predict mortality based on someone's zip code.
Right.
Because we know the lower socioeconomic status, we have more drug abuse, smoking, obesity, et cetera, heart disease, as a function of socioeconomics. So I guess what I'm trying to say is the playing field is not level here.
Sure.
You're already dealing with a number of other problems. From my standpoint, this assumes that the playing field is level.
You're absolutely right. And if there's an opportunity for us to do that, then if you have suggestions on how we can level the playing field, let's have that conversation.
Well, if we could, we would have done it a long time ago. But the other thing I will say, too, in terms of medical doctors and they being shut down, et cetera, as a psychologist, we make far less money than medical doctors, and we put more time in minute by minute for services. So a med check, they may get a lot more than what we spend in an hour counseling. So what I'm saying is those kinds of cuts, although we're saying we're going to infuse more money into behavioral health, it's going to put a lot of us out of business, and
Understand?
especially those who aren't psychologists.
Sure. And I'm not going to advertise that this is going to save the whole system.
Sure.
It never was intended to be that way. It was intended is to keep us from driving off the cliff because we are getting ready to destabilize that system if we continue with the rate, even if it's a smaller cut, the rates of cuts over the next few years.
We know that we're all going to be sacrificial lambs across the board. Again, socioeconomics, I think, are going to play a much bigger part than maybe this plan accounts for.
Thank you. Thank you, Doctor. Appreciate it. Hi.
I'm Lisa Schulteberger, and I'm the owner of a speech pathology clinic. And I know anything about the playing field. I don't know anything about that. I only know what's happening in my practice. And we were sent over to Triad to have our approvals for all of our PAs, for all of our therapy. We took our cuts, the
3% January 1, yeah.
We were able to survive that. The 25, no way, we'll close our doors. We're not surviving now because of Triad. We took the cut, our paperwork quadrupled.
Right.
We are now having such problems getting kids approved for anything that I had one of my therapists got hung up on day before yesterday, and I was doing a peer-to-peer yesterday, and they mentioned this lady's name, and I said, oh, she hung up on one of my therapists. She's the supervisor. I mean, come on, we're being treated like crap. We really are. They hang up on us. They tell us all this research, say we're not approving it because of the research, we're not approving it because of this. We're the professionals here, and we feel like that in my office that we have more education than the ones that are approving us. And it's very frustrating. So not only has our income gone down, our caseloads have gone down 50%. So we're working, it'd be like, I know you took a pay cut or whatever. Okay, now let's give you so much per hour, but you can only work 20 hours a week, because we're not going to let you have more than that.
Sure.
I mean, it's a death, we're going to go out of business,
Okay.
basically. And I've heard that from all the other speech pathologists as well as doctors.
For a couple things. So make sure I get the name of the supervisor or if you got the name.
Sure.
So,
It doesn't matter though. I had
well,
one
because
tell
because no, it does matter. It does matter because that's not acceptable.
Well, I had one speech pathologist tell me on a peer-to-peer that I should go get a child and take her to the dentist so that she can get dental work so that we can do better services on speech machines. I'm sorry, we don't do that here.
Right.
And this is what we're being treated like every single day.
Right.
And you get 4 sick sessions for 3 months or 90 days. That's ridiculous.
Sure.
So that's my 2 cents.
I appreciate that. Stick around afterwards though, because I want to make sure I get that information. Okay.
Sure.
Thank you. I got 2 folks coming. You can stand behind each other. It doesn't matter.
Go ahead.
Okay.
I work in a pediatric clinic in Kay County where there is not any medical professionals. It's very hard to get into. Our town, because of meaningful use, they've lost most all their doctors. We're not going to get any more doctors. That's it. We're done. With these cuts and in doing the vaccinations especially, the VFC program has increased more and more work on us. This cut will give us $12 to work with the state. They're going to eat just about all of it up. So why are we doing this? We're coming to the point where we may just cancel a medical home because that just costs too much. You're giving us too much work to do.
Understand.
Way too much work. And speech pathology, you were talking about that. We get them in a referral. Well, they can't get in right away. Well, they got to have a doctor's visit within a certain time frame. Well, then that means, okay, you got to come back. We don't know why, but you got to come back because that's the rules. Those are the things I'm looking at.
Thank you.
My name's Dana Broyles. I'm the Director of Nursing for a small private duty agency out of Tulsa. We provide nurses to special needs children from one end of this state to the other. Bartlesville, Hugo, Broken Bow. While your PowerPoint is impressive, what you haven't addressed is across-the-board cuts of 25%
Right.
June 1st. You ask our agency to take a 25% cut in $25.20 is what we are currently being paid to put a nurse in a home. You've already taken 3% away from us. Now you're going to take 25%? Where would you like me to find nurses to work in special needs homes with children with trachs, vents, they can't walk, they can't talk, their parents need to work, they're not daycare appropriate, at $13 an hour? Where am I going to find them? Our doors are going to close, and you're going to have 26 of our patients in the hospital or dead. So I'm asking you now, please address the 25% cuts for little people like us who provide a very, very valuable service.
Thank you. So I thought I addressed it. Let me address it again. I'll be more specific. We have said all along that 25% is not something we absolutely ever want to do. And we're trying to, and part of it is we have to go to the legislature and make the case that this will not work. So I'm taking stories like yours because I'm getting them. And I'm taking them to lawmakers and saying, we've got to be able to avoid this situation. I cannot tell them how to fund it. What I'm going to tell them is how much we need in order to avoid that situation. What we need in order to be able to maintain the provider base. And and so I think the most immediate way, in my opinion, in order to address it from a funding standpoint, if we're dealing with a budget shortfall, people have got to come up with ideas for revenue. The revenue that we're putting forward as a suggestion is a $1.50 increase in the cigarette tax. If they did that by a supermajority in both the House and Senate, give it to the governor, and it was signed, we believe that would be started July 1, and it could absolutely minimize what we've got dealing right there. But I can't control that. The only thing I can control is whatever number they give me. But what I didn't want to happen is that they provide a budget agreement, and then I tell you all, hey, by the way, what that budget agreement means is that. You have to know ahead of time. I hated having to start that public notification process. But I wasn't going to surprise you with it. So we're going to work. I hope you'll work with us.
So, what I hear you saying, and first of all, I want to say that I understand this is a tense situation, and for a lot of us, I'm a therapy clinic owner. Whether we stay in business or not, and that's a big deal. I get that. I also understand, if I'm hearing you correctly, that this is out of your control. And so I appreciate what you're doing in trying to engage the legislature to take this budget shortfall seriously enough and provide a plan that gets us back on track. Because I get that you can only do so much with the money given you. So thank you very much for that. I had a couple questions on that. So what I heard you saying, I just want to make sure I'm repeating it back to you, is that if the legislature were to approve the cigarette tax, you think that we could avoid the 25% cut effective July 1st?
Yes, June 1. I mean, if they did it in May, then there's no reason for us to start that. The reason I have to start it in June is because of the 12 months. But yes.
So would there be? I think we have, because we had projected a 4% cut at one point. Would we assume that 4% cut is going to happen, or would we stay at 86.5%?
Well, I think it's going to depend. And if in other words, if our whole ends up being $235 million and the cigarette tax produces 182, number one, it wouldn't all come to us. Some of it's going to have to go to the Department of Mental Health. So if 100, let's just say 150 million, then I have no idea, but if 150 million came, so then we'd have to balance $80 million in cuts.
So here's my question: if I understand your presentation correctly, you're actually only shortfall the 100 million, but you lose federal matching dollars of another 235 million.
No, our shortfall today is 100 million.
Okay.
And we know that with the budget deficit, there's going to be a cut. We just don't know how deep. So we went back to the governor's budget to make our estimate.
I got you. But a significant portion of what you'd have to make for the rate cuts loses federal.
Absolutely. That $235 million is all state dollars.
Okay. So it's $235 million state dollars, and then the rate cut includes the federal dollars.
Exactly. Yes.
So you really need $235 million to get back to where we are, or we hoped we would have been.
Yeah. I mean, so and I know it's complicated. And I don't mean it to be. If we're just assuming what the budget is today, we would need $100 million to maintain the rate.
Okay.
Okay. But if we're basically going to cut from where we are today, then we're just cutting down.
Sure.
So we're going down to maybe that 15% line.
So hard to tell for sure, but you need a lot of money, somewhere between 100 and 235 million.
That's right. And then that's where I think it's difficult, because you're right. We're going to need at least $100 million. But if they have to cut us, then we're going to need that difference.
And if I understand,
and then we lose the matching federal dollars.
And again, I apologize if I'm monopolizing time, but
no.
If I understand correctly, what you're saying is, I don't want a speech therapy clinic to close. I don't want a nursing home to close. I don't want any of these places to close. But I'm tasked with this much money to cover the whole thing, and I can't change a lot of those variables. So really, what you need is more money. So here's a question I have for you, Nico. What do you need us to do to get you more money?
There's a limit to what I can do as a director. I cannot tell you to lobby. I cannot tell you to take any particular action.
All I'm telling you is this is the case. This is the situation we're in. How you choose to address that with your elected officials is how you choose to address it. All I can do is present the legislature as well as the public who asks is here's our situation. We don't appropriate money to ourselves. That actually happens down the street. So,
Okay, well, what I hear you saying is you can't tell us what I'm about to tell us to do. Since I don't work for the Oklahoma Healthcare Authority, although I feel like I do at times, this is the deal, right? We can't be mad at OHCA for this. We need to talk to our legislatures about it. And I get that there's some ideological ideas that we have about the way things work and the way dollars work, and everybody has a plan until they get punched in the face. That's Mike Tyson. And we just got punched in the face, and if we don't get out there and start talking to our legislature to approve this plan, we're going out of business. That's the long and short. There's nothing he can do to change it if we can't get the money. So I would encourage everybody listening to this to call your legislature and say, I approve this plan. I think it's great. If you don't vote for it, I will come vote against you the next time. He didn't tell me to say it, I promise. But it's the long and short of it, folks. This is a dollar. Like, we're an oil and gas state. We don't have the money. We need more money. We've got ways of getting the money. We got to take advantage of it. And we have to be the voice to make this happen. Does that make sense? Appreciate your time, Nico.
My name is Kimberly Scholes, and I'm a director at an agency.
take the mic a little bit deeper.
I'm short, sorry. My name is Kimberly Scholes, and I'm a director at a behavioral health agency. I generally don't speak, but I come to a lot of the meetings. And I've tried to listen to all sides. Prime example, when I get up on Sunday morning, I watch Flashpoint. I don't know if anyone else watches it, but I do. And I guess I was kind of taken back listening to them this past Sunday identify that there was $500 million that could have been accepted by the state that was turned down. And so I would like to know what would the outcome or the outlook of our state be if that $500 million would have been accepted. And as I'm listening to them Sunday, I heard all parties at the table state that at this point, there should not be any funding that's not on the table to be accepted by the state of Oklahoma. Why are we not considering accepting that funding? And then just this morning at 9 a.m. when I'm watching Governor Fallon on the news, that same question was posed to her. And she said if given the opportunity to take it a second time, she would turn that money down. That was this morning. So I'm asking you,
Right.
I know that someone has looked at what our state would look like if that funding was accepted. But we're not being told what the state would look like. We're being told the state that the state is in right now.
It'd be pure speculation on my part. So here's what I've got to face. My reality is I can't go back and change what happened with that decision on when money was accepted or not accepted, when those decisions were made. I can't impact what oil and gas did. All I'm focused on is what's in front of me. And what's in front of me is this situation. And so what I've offered is using federal Medicaid dollars to fix a system, to stabilize the system over the next 4 years. And so I don't think you can talk to your legislators, but I don't think they're gonna approve a Medicaid expansion. So I had to come up with a plan that was not Medicaid expansion.
Well, I'm doing the math, and you say you need 100 million, and there's 500 million that could be accepted.
Well, that's different though, because those are federal matching dollars.
Okay.
Okay, and everything we do in Medicaid's matched. So we got to be able to come
So
up with
then
state dollars.
the state would have to come up with
Well,
a matching amount.
right. So for example, right there, if we were to start this plan, get that 500 million federal dollars, we got to come up with 26.
Okay, and I understand that. I do understand that.
Yeah.
But from what you're saying, the cigarette tax is how we're going to come up with our portion.
That's my suggestion.
So are we still not going to be accepting that 500 million?
If we get the cigarette tax, then we're going to get the federal matching dollars to do Insure Oklahoma to stabilize Medicaid rates.
But that has nothing to do with the funding that we would have gotten for the Obamacare plan.
I can't deal with those decisions in the past.
Oh.
Gotcha.
Wanda Felty. I'm a
Can you
mom.
make sure you're talking to the
Am
microphone?
I talking in the
Yeah.
microphone? Thank you. I'm a mom of 3 girls, and all 3 girls utilize Sooner Care, and I utilize Sooner Care for one of their pregnancies. So I'm looking for more details on your numbers here, Nico. On the rebalancing side, on the side with the balance, the seesaw, you've got 22% off of Sooner Care.
Right.
So who is that?
So what that is projecting 175,000. These are kids and pregnant moms above 133% that don't go that would come off Sooner Care and go into the commercial market.
Okay.
Okay.
So,
So,
and then
and-
under that, you've got a 30% reduction for the uninsured.
Right.
So, because I think you're missing some numbers here when we talk about savings. If we get uninsured insured, then they'll quit using the ER as a triage or a acute care. So there's some savings
Yeah, there's some indirect
that's-
savings, right?
that you don't have on here. And the reason I say that is
Right.
my daughter, who has very critical conditions, ends up being admitted through the ER, and it is a clinic in there. She's got a acute crisis, medical crisis, needs to be admitted, and we're filtered through the flu. So I'm interested in that piece and looking at those numbers and the reality to the other side when we're talking about savings, because your numbers is strictly about Sooner Care savings,
Right.
and there's a bigger piece to this, if I'm correct.
No, I think Wanda, I think you're absolutely correct. There are indirect savings that we don't have necessarily corrected here because if we reduce ER utilization, if we are improving our compliance with prescription drugs, things like that, that's going to actually save money.
Okay. So eventually, do you think you can get us some good numbers on that? too?
Absolutely, and I think that's where this has only been public about a week, and so what I mean by that is that I would love the opportunity to work on it some more, and so that's absolutely something we can do.
Okay. Thank you.
Absolutely, thank you. And kind of follow up on that, just that population that we're talking about, those kids and pregnant moms are typically less expensive than the population that we're trying to stabilize in the uninsured market too. So.
My name is Joyce Lona with the CMHC in northeastern Oklahoma. And first of all, I just want to say thank you. And just to reiterate what the gentleman said, that this is our problem. I mean, this is really not the Healthcare Authority's problem. It's our state of Oklahoma's problem. And I just want Nico, if you would, to reiterate the fact that there has been no other plan that our legislators have heard. Nobody else has brought out any kind of solution. And I just, if you would, just reiterate
Yeah.
that there's been no other plan.
I have seen no other plan to address this. I would love to. If somebody has something to. Not specifically for not specific nothing specific to Medicare, nothing specific to Medicaid, nothing specific to the Sooner Care program. No. I got somebody at the mic, so we'll go back to the mic.
Hi, I'm Christina Bennett, and I'm with the College of Public Health over at OU.
That's all I got to the mic up.
I'm wondering, and Dr. Sherry Kinney and I were both wondering, can you talk a little bit more? Can you talk a little bit more about the federal premiums assistance and where that money is coming from, and the 1332 waiver, and exactly? And I know that you were saying it's a conjecture at this point, but can you go into a little bit more detail?
Sure. So that's if we were to do this plan, then we basically have 3 years to figure out making sure that we don't put people into an unaffordable or uninsured status. Number one. So there are opportunities to do that. So people in the state today above 133% have access to federal advanced premium tax credits in order to buy insurance. There may be a way to use that money and either group it together and help people buy insurance, or just help educate how people can use that on their own. And then when they make those choices, when they take those tax credits, they can choose from different plans. They have different premiums, different deductibles. The market may look a lot different in 3 years. In all likelihood, it might. So what we're saying is there's opportunity to use tax credits available to those individuals today, but actually be available to them in 2019 and 2020, and help them purchase insurance on that commercial market. So either individually or as a group, those kind of things. And so the 1332 waiver is a new waiver by the Treasury Department that actually helps, that could actually allow states some flexibility in how you manage those tax credits.
And have you seen other states actually do this?
No, haven't. I mean, it's a fairly new opportunity, and as far as I know, no other states have done that. But what it does is it's supposed to allow states that flexibility. And so I think that's something we ought to look into as we try to rebalance the program.
And do you think that the people you're trying to move will be willing to move onto that plan, or do you think that you would actually end up losing them?
Well, we would do our darndest to make sure we didn't lose anybody. Not most people don't like change. So it would be a lot of work, but we're willing to do the work. And I know we're getting some statements online. I'm not going to read them, but we'll take those. If somebody has statements and questions online, then we'll do that. I mean, if somebody has questions online, we can read them.
I'm Sherry Murphy. I'm with Willowcrest Hospital. We're an inpatient psychiatric hospital for children and adolescents in Miami. If the $1.50 tax were to pass, do we have any kind of guarantee that all that money would come to us? Because I know we have education, we have prisons, we have everybody out there screaming for money. So
There's no way I get now. There's a way for them to apportion it, so they can lock it into that, but that becomes that's a legislative decision, not our decision. So I think it would be if we're going to go fight for that as a funding source, it better come to Health and Human Services.
So to add to what he said, we need to make sure that we tell him it comes to us.
Hello, Carly Putnam, Oklahoma Policy Institute. Are you expecting to have projections past 2020 at a particular moment? I know you're presenting it as a 4-year plan, but I'm assuming it would extend past the 4-year period.
Yeah, there'll become a point where we'll have to project past 2020, but just for the construct of the plan, it's just 4 years.
And
right now.
is the 176,000 expected to be the sort of eyeball estimate at 2020?
Yeah, I think how quickly we get there. We haven't run that projection, but I didn't want to be accused of trying to say, well, it's only going to cost this much now, but
Yeah.
If it fully implemented, it's going to cost that much. So I'm using the fully implemented number.
Okay, and then when you do the projections past 2020, you'll go past the 176,000 as well.
Yeah, well, I mean, I think it depends. I mean, what's the demographic look like in terms of people in poverty, people below 133%? It's going to be a factor. Our traditional participation rate in senior care is about 85%, so it could go up.
Okay.
So those are some things that we have to figure out. Some of that we won't know until we get into the experience.
Thank you.
Thanks.
With Maxim Healthcare. Much like Dana, I also am manager of a private duty nursing agency here in Oklahoma City. Are you guys going to send out a detailed press release of how this plan works? Because I'm just one voice. I think my families and the parents of my families really need to get on board with this, as well as talking to lobbying their representatives. So
Absolutely.
I would like to be able to submit something to them so they can also get on board.
Thank you for that. So what we have this online, but if what you're asking me is you need a more narrative piece, we can put that together.
Yes, please.
Absolutely. Absolutely. Thanks. The question online is, has anybody considered raising sales tax? That's not our suggestion. I know there's the sales tax increase that some have offered for education, but that's a separate one. Nothing that we've suggested from Health and Human Services.
Hi, my name is Mickey Jack, and I'm with Your Key to Change. My question is, this plan, and I appreciate the effort in developing it, but it hinges on the participation of a community or a population that already struggles financially. My question is, we haven't addressed the affordability of the new Insure Oklahoma plan, and how will this plan offer a more affordable option than Obamacare did? What is going to be the plan to offer care that those already below the poverty level can afford.
Right. So if we do Insure Oklahoma, and we look at, I'll give you a state like Indiana, who did something very similar with this. So people will be expected to have a premium out of pocket in order to get access to the program. But that could be as low as $1, could be as much as $20, $25. It's going to be sliding scale. That has to be negotiated with our federal partner. But we believe that there's going to have to be a premium in order to get the process. So you're saying, well, what if you just did straight Medicaid expansion? You didn't have the co-payments and premiums. Frankly, it's not an option for us. So it's either have something available in which there's some out of pocket in order to have Insure Oklahoma, or have nothing at all. That's kind of what we're faced with.
Lola Edwards, I have an Advantage agency. When we used Insure Oklahoma before and we had employees that would participate, there was a cap, and once we got to 99 employees, is that gonna be a play anymore? Will the cap be raised?
Yeah, the cap is actually raised now, so we're up to 250 now. That was a recent change, probably last 6 months. And so
Okay.
we were able to raise that the last 6 months to try to make sure that we broaden that access to Insure Oklahoma. And so the Insure Oklahoma employer-sponsored program in this plan, it stays untouched.
One other question with all this going on, and I know House Bill 1566 passed last year, which will bring managed care in. Where are we at with that and starting that? It's a new program that's going to cost obviously a lot of money to get started. Is the Healthcare Authority going to be going into new programs? Or are we going to kick that down the road till our budget situation is better, or how's that going to go?
So our requirement under the statute is to put out a request for proposal for care coordination. We are still in that process of doing that. I anticipate, we kind of got behind schedule a little bit, so that may be later this summer, early fall. At some point, if and when there's a price tag, it'll go to our budget request, and it'll be in that number. So at some point, they'll have to fund it.
One other question, if I may. As an Advantage provider, we contract with the Healthcare Authority, but our budget's at DHS.
Right.
Will any of this process help the DHS budget, or is it all within Healthcare Authority?
Yeah, I think it's within, and that's great. I mean, I think that's a conversation we have to have. We haven't had a direct conversation with DHS about their budget, because I don't know what their budget situation is.
109 million for next year is what they told us yesterday.
A cut, or
That's their whole, and
that's their whole?
yeah.
How much are they taking out of it? I haven't talked to the director, so I don't know.
Well, we had a 3.5% cut September 1st, so we were the first program that was cut,
Right.
but even before the revenue failure. So, and we're at the point, if there's any further cuts, we're like everybody else, we're out of business. So.
Okay. Well, DHS is within the Health and Human Service Cabinet, so they're absolutely a player in this conversation. Yeah, if you can read me the question.
Okay.
I'll,
Is there
I'll,
a plan
I'll,
in place to allow therapists who want to provide this cut out to provide therapy without the documentation position if they all drop out?
okay, so you're going to have to repeat that one in the mic, so I'm not going to be able to repeat it.
Is there a plan in place to allow therapists who want to write out this cut to provide therapy without the documentation from a physician if they all drop out?
Let me put it on the list. I don't, until I have a chance to look at it, I don't know if we can, what we can and can't do in that regard.
If we are going to consider an increase to tobacco tax, wouldn't it be worth the legislator to legalize marijuana? Colorado is expecting $100 million in taxes in 2016.
If somebody wants to, yeah, Martin, Doctor, yeah.
I'm staying out of
If
that
somebody
one.
wants to float that to the legislature, I'll let them float that.
Marty
ahead.
Dunlap, general pediatrician. What are your projections of what the cigarette tax would bring in? I mean,
Yeah.
will that fill the hole, or is there still going to be a hole?
$1.50 brings in 182 million. Since I don't know what the hole is, it could get really close, but I don't know what the hole is. So, but all I know is if we don't, then we're faced with whatever the revenue is available, and so devastating.
And if the legislature doesn't have a supermajority, but they have a majority, then it goes to the vote of the people in November?
They can send it to the vote of the people if they don't have a supermajority.
And if it doesn't even have a majority, is it dead then?
I believe so. I can't cut out many of you, so I've got somebody at the mic. Go ahead.
Hi, my name is Mickey Gorel. I have a question about dual eligibles. So my mom has Medicaid and Medicare, and from what I understand, if you bring in managed care, that they're going to require people who are on Medicaid to go on to a managed care Medicare plan.
So for the age-blind disabled population, which includes dual eligibles, that's the RFP that's under development right now, which could include moving that population into a managed care situation, yes.
Are there any options for those individuals to keep and manage their own Medicare?
No, I don't believe so.
Okay. And then we haven't talked about the indirect costs to providers under managed care. I mean, from what I understand right now, those providers deal with just your agency and their billing and reimbursement. And if they bring in managed care, from what I understand, is that those billing and reimbursements would now be under federal regulations.
Well, no, we're all under federal regulations.
Right.
So whether we're dealing directly with the provider or if there's an intermediary managed care organization, we're all dealing with the federal requirements. So not sure necessarily how to answer your question in that regard.
Okay.
But if maybe I'm misunderstanding, so we can spend some time more details, make sure I'm not misunderstanding.
Okay. Thank you.
If you got some more yet.
Educate and motivate these 175K who will likely fear the move and not understand any of it?
Well, that's what I hope, if we're able to have that conversation, that is something that we can do together. It's not going to be simple. It's complex. I don't have the answer, but I think we've got to do it right. And part of that's just going to be a lot of communication in a very transparent way. Okay. All right. Well, if there's any online that we haven't answered, we'll answer electronically. If there's no other questions here, we'll go ahead and wrap up. I'll be around. I know some of my staff will be around. Before you get up, if my senior staff, my direct reports, would you stand just so they can see you in the room in case they have a question? So I got Nicole and Lisa, Taiwanda, Becky's back there. So if you have a question and there's a line to me and you want to not wait around, one of these folks can help you out. Thank you again for coming. Appreciate it, and hope to continue to work with you. Thanks.